Assalamualaikum and a very good afternoon. Thank you to Mrs. Chia Lim for your kind introduction, and thank you to all audience for spending your time during lunch break and also your weekend. And I hope everyone is in a good health and staying safe. So today I would like to share our research finding on the topic of adherence to individual medications in chronic kidney disease patients, a multi-centered study. And this study was actually conducted in collaboration with Universiti Kebangsaan Malaysia and National Committee members of Renal Pharmacy, Ministry of Health. As for introduction, medication adherence is universally recognized as a major clinical issue in CKD patients due to complex regimens and high pill burden. As what we concern most, they are generally prescribed with an average of 10 medications that needs to be taken daily. Prevalent rates of non-adherence in CKD patients were reported in wide range, which was between 12.5% to 98.6%. However, definition of medication adherence is often inconsistent, and various methods used may overestimate adherence due to overall assessments of medications. In addition, adherence is also affected by various factors such as patient-centered, therapy-related, social and economic, disease and healthcare system. Medication use and adherence should be a great concern in management of CKD patients as it affects progression and complication of the disease. Most studies use various tools that are usually associated with general adherence of multiple medications or focus only one classification of medication. The score use has its own limitation. As such, we are unable to identify which medication are problematic for the patients and the reasons for non-adherence towards it. To date, none of the available methods are considered as a gold standards for the adherence assessment, and there is limited evidence on medication adherence in our CKD population. Therefore, by conducting this study, assessment of each or individual medications taken and predictors of adherence could potentially aid in more focused intervention in improving medication adherence. So our general objective of the study was to assess adherence of overall and individual medications among CKD patients, and specifically, we aim to identify the reasons that influence medication adherence, to compare adherence of overall and individual medications, and to identify predictors towards the medication adherence. So this study was a multi-centered, cross-sectional survey conducted in 10 tertiary hospitals across Malaysia under the Ministry of Health and Ministry of Education from June 2018 to June 2019. Patients diagnosed with CKD with or without dialysis with an available current serum creatinine value took at least one medication and understood either Malay or English language were included. So researcher-assisted survey were performed via face-to-face interviews, assessing both overall and individual medication adherence using validated questionnaires with two different tools. First, we use overall assessment tools developed by Hassan et al. 2008. Now, during this time, our MyMark tool is not yet published and allowed to be used. So secondly, assessment on individual medication were performed based on study done by Laboratory et al. 2016, and medication knowledge assessment was performed based on Marva Nova et al. 2011. So for sample size, we used Craigie-Morgan formula. We targeted 500 patients with additional 30% of possible dropout in order to increase the power of study and allow for subgroup analysis. So we used SPSS for data analysis on descriptive statistic and multivariate logistic regression for predictors of adherence towards overall individual medication. And ethical approval was obtained from UKM Research Ethics Committee and and Ethics Committee, Ministry of Health. So all questions were included with informed consent. So this is study tools as in the structured data collection form, and basically we are using the subjective methods of adherence assessment. First, we use overall medication adherence assessment tool developed by Hassan et al. Adapted with permission, consists of 10 items, including both drug taking and stopping behavior. These tools using Likert scale, the score 75% and above is considered as adhere. Secondly, assessment on individual medication was performed based on study done by Laboratory et al. 2016. We calculate the percentage of how many medications screen taken by patients from the total prescribed dose for the past 1 month from the interview session. And the score 80% above is considered as adhere. They were considered as adhere when all scores are 80% and above for all medications. So finally, we assess their knowledge assessment by using defeat assessment and that we are using for our MTech patient. And the data was then transferred into the percentage. As for results and discussion, a total of 491 patients were recruited with mean age of 54.5 years. Gender was found to be approximately equal, and subjects were predominantly Malay, which reflects our own population. And the average number of medication prescribed was found to be 7 per day. And most patients included were found to be at stage 5 CKD. And the most common comorbidities among the subjects were hypertension and followed by diabetes. So interestingly, we also found that 16.7% patients admitted to taking complementary alternative medicine, and the most popular use was herbal, which made up 76.8% of CAM users. So this is the results of overall medications adherence assessment that consists of 10 items with 2 domains of drug taking and drug stopping behaviors, as what I have mentioned before. So overall assessment was found to be generally positive, with 82.3% adhering to the medication and a significant improvement compared to other studies. So one reason patients will adhere to their medication was due to the fact that they agreed to medication instructions given to them by healthcare professionals. Therefore, healthcare professionals play an important role in educating patients in order to achieve full understanding of what the medication that they are taking. And in addition, a good patient healthcare professional relationship has been shown to improve their medication adherence. So looking at individual adherence assessment, only 27.5% was found to be fully adhered to their medication. In contrast to overall assessment, we found that patients were mostly adherent to types of antihypertensive, which were ACE inhibitors and ARBs, then followed by antiplatelet. However, the most common medications patients were non-adhered to were phosphate binders, as what we have encountered in our current practice, and followed by insulin, which made up half of the patients. And the main reason for non-adherence to phosphate binders were unpleasant taste, as they have to chew the medications that cause reduced appetite. Forgetting to take the tablets was also the main reason that leads to most patients skipping their phosphate binders. Whereas barriers to insulin adherence were they found to be afraid of hypoglycemia and feeling worse after insulin injection. So from this finding, we need to further look into the solution. For example, extended counseling and education on the specific problem of the medication, to ensure that they understand what they are given for the management of their disease and also the target therapy. So when compared between both overall and individual assessment, it was found that a significantly lower number in individual compared to overall adherence which demonstrate the strict assessment of individual medication. And this can be because a patient could adhere to their multiple medication frequently and exhibit various medication taking behavior. So therefore, it is vital to understand how patients routinely manage their medication because different intake behaviors could associated with different outcomes. So to answer the third objective, we have identified predictors of adherence towards individual medications. Univariate and multivariate logistic regression analysis was performed to identify demographic characteristics that predicted overall adherence of individual medications. And the multivariate logistic regression model has demonstrated that the age, number of comorbidities, number of medication, drug knowledge score were significant predictors of individual adherence when holding all other variables constant. So patients aged 55 years and above were 2.3 times more likely to be adherent to all medication compared to the younger patient. Those with less than 3 comorbidities and less than 7 medications increased the odds of adherence by 2.1 and 2.2 times respectively. Having a drug knowledge score 80% and above increased the odds of adherence by 8.7 times compared to their counterparts. So in our study, we used the result of individual adherence due to the strict criteria as patients were considered adherent when all individual medication taken achieved 80% and above. So in this study, we found that younger patients are less adherent compared to older, presumably due to a busier lifestyle, while putting more focus on their professional and social life. So besides, patients with multiple comorbidities increase the treatment burden that leads to polypharmacy, a complex regimen and a complicated administration of medications which resulted in non-adherence. And this is a very important point, as if possible, we want to reduce the pill burden that needs to be taken by the patients. So in addition, lack of knowledge about the indication and effects of each medication was also a reason for non-adherence, as similarly found with other studies. So for that reason, knowledge of medication is also important as significant predictors for medication adherence. And this is part where pharmacists play a vital role to educate patients on their medication and disease, as well as the target therapy. So we need more trained pharmacists to give better approach in the management of CKD patients. So limitation of our study is actually, as what I mentioned before, it's kind of a subjective methods for adherence assessment. All measures were based on the respondent self-reports, which may cause reporting or recall bias, and to minimize recall bias, pill counts and the use of diaries for medication intake can be used for future research. The choice of method to measure medication adherence will also be controversial, as currently there is no gold standard to assess the adherence assessment, to assess the medication adherence. So several other factors that may also influence the medication adherence, including socioeconomic status, educational level, knowledge of disease were not assessed. As for conclusion, our current practice of general assessments of medication overestimates adherence level among CKD patients, and it is recommended to perform individual medications adherence assessment to clearly determine adherence among this group of patients. However, we still have limitation on the established tool to be used in our general practice. Lastly, as a pharmacist, we are responsible to give our best for patients' care and should be continuously perform our late intervention with appropriate medication education in order to identify and may help to solve specific problems faced by the patients. So with that,